Good afternoon, everyone. Myself, Dr. Sonal Mehta. I'm lead medical advisor in intas. And Intas Pharmaceutical is a leading pharma company headquartered in Gujarat, India, with presence in over 17 countries across the globe and has strong presence in fertility business. As you all know, we all are stuck in COVID-19, and it's been probably the worst catastrophe of our lifetime. And gradually we are reopening and restarting our activities. So today, being a knowledge partner and commitment to the scientific update, we have planned from Intas Women Health, headed by Mr. Satpathy, have organized this webinar on post-COVID-19. I welcome you all to the webinar on COVID-19 given by eminent faculties Dr. Alpesh Doshi and Dr. V.M. Thomas. You all are requested to put your questions through the chat box. And first will be the Dr. Alpesh Doshi. He is the consultant embryologist and co-founder of IVF London, co-founder and director of embryology and PGD Academy. Alpesh previously worked at the Center of Reproductive and Genetic Health as a director of embryology for 19 years and was pivotal in optimizing the success rates. He was also an honorary consultant at the Reproductive Medicine Unit at NHS Trust. He holds a postgraduate degree in human reproduction medicine. Dr. Alpesh is a diplomat of Royal College of Pathologists and also ASHRAE certified senior embryologist. He has been an executive committee a member of several international embryology societies and holds a very active interest in promoting education platforms. He was among the first scientists to bring the egg and embryo freezing technology of vitrification to the UK in 2007. He is a world-renowned expert in the biopsy of human embryos and genetic testing. Dr. Alpesh has authorized several papers in high-impact journals and written several book chapters. He has been invited speaker in many international conferences and workshops, as well as several health chat shows on television, including ZTV and ITV's This Morning. Alpesh has a special interest in fertility preservation, peri-implantation genetic diagnosis, and genome editing of embryos. I welcome Dr. Alpesh. I hand over to Dr. Alpesh and to speak on the webinar on SOPs for IVF lab post COVID-19. Over to you.
Thank you so much, Dr. Sonal. Can you all hear me? Just someone tell me that you can.
Yes, sir.
Brilliant. Thank you so much. Absolutely a pleasure to be speaking again on a platform organized by Intas. And I must say that this is an amazing initiative to bring the latest kind of guidelines on opening up of IVF clinics to countries such as Africa or continents such as Africa. And of course, I come from Africa myself. I'm from Kenya. So I've seen some of my good friends from Nigeria who are online. So lovely to see you all. And I'm very pleased to be talking about opening the lab up or opening the IVF clinic up post-COVID-19 or during the pandemic. And as all of you know, there is going to be a new norm on how we introduce IVF back into our clinical routine. And this is not going to be the way we used to do things before. There is going to be a layer of safety measures that we all take at every level. So today's talk is going to focus purely from my end on the lab aspects of it. But like Dr. Thomas, I also run an IVF clinic, and obviously I have an involvement at every layer of the clinic to ensure that there is safety measures, not just from the admin end, but also clinical. As you may or may not know, in the UK, we are regulated heavily around this whole aspect of reopening post-COVID-19 by the Human Fertilization and Embryology Authority. And just last week, we had reapplied to the authority to reopen, and this involves a huge self-assessment questionnaire that we have to do as a clinic to prove to the regulator that we are able to reopen and offer services in a safe way. Rona, can I request, please, everyone to turn off their mics, because
I have already muted everybody, sir.
And can you also please turn off their video cameras?
Sure, sir.
they're all adding on, they're all joining in with their video cameras on, please. Yeah, so I will take you through the regime of how we have successfully implemented working in the COVID pandemic and offering safe IVF. So I'm going to share my screen now, and here you are. I hope you can all see my slides. And obviously we know, as I said, that there is going to be a new norm. So all centers have now been applied to, or have been asked to apply to reopen. And I'm proud to say that we were one of the first clinics in the UK to get the all clear to reopen after all our risk assessments and protocols and policies have been gone through or risk assessed by the authority as well. So as I told you earlier, we are supposed to fill in a 4950 question self-assessment questionnaire, which totally ensures that the clinic is ready to open up with all the control measures in place. So obviously, during the whole lockdown, it was quite important from a regulatory perspective that our patients are also kept up to date on what's happening at the clinic level, what the clinic is doing, what safety measures, what control measures the clinic is taking. So we all have a very important role to play when it comes to patient awareness or managing patient expectations. And hence, one of the first things I would like to say is that you need to manage these expectations by regularly keeping your patients updated. Imagine those patients who have got frozen embryos in the tank. All they know is that they have these very precious embryos, but have your patients been reassured that those embryos are safe? You may know that, you may have a rota in place to ensure that someone from your team is regularly going to the clinic to update or top up liquid nitrogen, but your patients don't know that. So it is quite important that you make patients aware about these kind of something that may be very normal to you, but to the patient, it's a huge concern simply because they don't know what measures you have in place. So transparency is very important in this whole COVID pandemic, whereby you're continuously communicating with your patients about everything you're doing as a clinic to make sure that their treatment, their gametes, and their embryos are held in a very safe and effective manner. Now, of course, you know, the whole process starts off with your admin unit, and you have to continuously ensure that your waiting room has enough patient information around what is expected of them during the pandemic. And of course, we will be talking more because you may have heard in several of my webinars that I have done that now there is a patient self-assessment questionnaire or a COVID self-assessment questionnaire for the patient. So every patient will be expected to fill in a symptom tracker or a symptom questionnaire before they come into the clinic. And of course, the more information that you can keep out in your clinic, whether through all your TV screens, please stop playing TVs at the TV channels now, because we have more of an important message to really relay to our patients. So try and play more education-related videos around COVID so that it actually empowers your patients and also educates them in terms of what is expected of them whilst they are on your premises. Please do take note of several professional body guidelines who have released some invaluable information on how clinics can now start up. So in the UK, we are privileged to have the Association of Reproductive and Clinical Scientists who have given out guidelines. The British Fertility Society, who have also issued communal guidelines with ARCs. We have the ESHRE guidelines, of course, which are more European, and the American colleagues have also released guidelines from ASRM with regards to how to reopen. And the beauty is that we work in such a digital era and everything is online. So please do make use of all the resources that are available to you, because simply you will need these, because these direct you in such a positive way on how to offer safe and effective IVF. And finally, I'd like to say from a regulatory perspective, they should be, in the UK, we're expected to have a code of conduct whereby your staff and your patients are both signing to ensure that they will keep the risk to a minimum on both sides, to the patients and to the staff. Now, obviously, reinstating the clinical services includes a triage of the patient. As I have said before, that there is a triage questionnaire whereby patients are supposed to be letting us know if they are symptomatic or not. And we expect two levels of triage for any patient going through. One is before the initial visit to the clinic, and the second triage is before they start stimulation. And of course, during this first and the second triage, if anything has changed in terms of their symptoms or they become symptomatic, then they will need a COVID-19 test. Now, apart from the triaging, as I said, the other important aspect of the whole process is going to be COVID testing. And again, as a policy, our clinic has ensured that all our patients going through IVF are going to be tested twice in the journey. The initial test is going to be an antibody test for IgG. This is before they start any kind of stimulation, to ensure that they do not have any kind of, to see if they have got antibodies to the infection. And of course, if they do have antibodies, they may not need a second test because they can be considered to be immune. But let's assume that by and large, a lot of your population is negative or do not have the antibodies for COVID-19. They will need a PCR, RT-PCR test, and we are going to be doing this between day 8 to day 10 of stimulation, just so we can catch the latter end of the journey that is going to happen in the lab as well. Now, it's quite important to understand that an RT-PCR or an IgM test is only telling you whether the patient has got an active infection. It is not necessarily telling you whether the patient is not going to be positive in 2 days. Okay, so essentially this test is only valid for a single day whilst you know whether that patient is positive or negative. So if the patient is negative at this stimulation check, then they can continue having IVF and even to the point of having embryo transfer. However, if the patient is positive for COVID, their cycle will be cancelled, and patients will be made aware that during stimulation, if they become symptomatic or they are tested positive, their cycle will be cancelled and deferred till later. The other aspects to bear in mind is that at the admin or clinic level, you want to make sure that there is social distancing in place in your clinic. Try and not pack in too many patients at any single point. Try and space out appointments for scans, for egg collections. If you're a very busy clinic, you may have to work in shift patterns. You may have to have a morning shift and you may have to have an evening shift. But it is your responsibility to make sure that you are minimizing the amount of people in your clinic. Okay, so to give you an example, in our clinic, we have set aside 30 minutes for every scan appointment. And we all know that the scan only takes 10 minutes, but we're giving it 30 minutes so that essential and adequate disinfection can also happen in between patients. Try and encourage your patients to make contactless payments and try and avoid taking cash. And I appreciate that in some countries in Kenya, or in some countries in Africa, such as Kenya, Nigeria, cash is a big way of paying for your treatment, but please try and minimize this because again, the virus can survive on paper for a long time. So again, all this is very important. Make sure that you do provide disinfection for your patients as well in the form of either a wipe or an alcohol gel at the entry point and the exit point, because essential disinfection is very important from a patient's perspective and obviously from the clinic perspective. And I've obviously talked about how we should spread the appointments apart. And of course, if you do are a very busy clinic, you may want to have 2 shifts. Now, we all know that the whole process has to start off with a very deep clean of your clinic. And when I mean a deep clean, I say all the walls, all the ceilings, all the floors, the benches, everything will have to be revalidated. Will have to be cleaned out with a active disinfectant. So we all know that in IVF or in embryology, oosafe is a very safe disinfectant to use. So again, I'm not saying that your walls have to be disinfected with oosafe, but certainly all your benches have to be disinfected with oosafe, because you don't want any embryo toxic disinfectant which has chlorine ions. So a lot of people have talked about sodium hypochlorite to be an adequate disinfectant. Yes, it is, and certainly at the clinic level it may be, but at the laboratory level, you may want to use an embryo safe disinfectant, which is equally active against COVID-19. It's important to understand that revalidation will have to happen of all the equipment. A lot of you may have already shut off all your equipment before the lockdown, or may still be in a state whereby you are closed as a clinic. So let's not forget that you will need to revalidate all your equipment, make sure that the operation performance, the installation is fine, that's fine, but everything that goes part and parcel of a validation, which is performance qualification and operation qualification, has to be redone to make sure that your equipment and its functionality is fine. For those of you who are working with nitrogen generators, for example, to pump in nitrogen into your incubators to maintain a hypoxic environment, it is quite important to understand that your cylinder will be full of atmospheric air. So you may need to drain that before you start purging nitrogen into your incubators to maintain hypoxic or 5% oxygen. So these are just some pointers on how all this revalidation is going to be very important. Otherwise, you will start seeing a drop in your results when you open up. Sterilization is very important. We all know that big box incubators have got a high temperature sterilization systems up to 90 degrees. In some countries, you may have a hydrogen peroxide bomb available. In the UK, we have specialized companies that will come the night before in the lab. They will just set up this hydrogen peroxide bomb. You keep all your equipment doors open, including your incubators, etc., etc. Of course, you can't be in the lab when this bomb is released because it can be toxic. But the good thing is that once it's released, everything is disinfected, and there is no concern about toxicity because it breaks down to air and water. Also, do keep in mind that you may have to change the air filters into your air handling unit, because you may have either shut the whole system down, and most importantly, we know that the air can also harbor this virus. So if you are going to be, and of course you are going to be turning on your air handling unit now, you want to make sure that you have a whole new set of filters installed in your AHU. If you are lucky enough to have an ultraviolet lamp in your flow cabinets, please do make use of this, not necessarily during the working day, but at night when all your tool holders, your consumables can be opened up in your class 2 cabinet, and for half an hour, the UV light goes on, and you can set it on a timer so that by next morning, everything has potentially decontaminated. So again, you can use any UV lamps, again, not necessarily during eggs and embryos being manipulated in the lab, because that could be dangerous. You cannot use UV whilst eggs and embryos are out, or when humans are around, because it can affect a well-being. So you have to set, if you do have a UV lamp, you have to set it on a timer. Okay. Effective sanitation protocols are very important. And again, this is part of the risk assessment that we had to do for the regulators before we were allowed to reopen. You have to prove that you have a very effective sanitation and disinfection protocol in between patients as well. Please don't assume that you're going to go back to working in the same way how you used to before, which is clean everything in the morning and then clean everything at the end of the working day. Now you have to be cleaning in between patients. Just to give you an idea, even the seat on which your patient sits in your waiting room has to be cleaned after the patient has left. So effective sanitation has to happen at all levels. Even in your phlebotomy room where your patient has sat, in your scan room where your patient was lying down, you must have a sanitation protocol for your ultrasound probe, because that is very important. That is a very intricate contact point. So again, these protocols are very, very important. And of course, as I said, in addition to in-between patient sanitation, your daily entry and exit protocol is also important. We now move on to personal protective equipment. And of course, all of you know that this is quite mandatory from now on. Embryologists are always quite used to wearing scrubs, but also please make sure that you are ordering regular pairs of scrubs. In our clinic, we are changing scrubs twice a day just to minimize anything that may be on our clothes. Of course, you may want to take an approach that if you step out of your lab, you may want to wear a lab coat. But again, I'm trying to minimize things which are contact points, whereby if the lab coat has the virus on it, then you're essentially putting it on your scrubs. So I prefer to tell embryologists, try and change 2 pairs of scrubs in a day. Yes, you have disposable gloves after each procedure, you have hats, you have masks, you have plastic aprons if you need to. Your employer may have to provide you with visors as well, just in case if you're talking to any patients. Try and have 2 pairs of clogs, one for the lab inside, one for the outside. And most importantly, I don't mean to demean this in any way, but your hand washing protocol is very important. I know we're all very thorough in the lab, but trust me, I have seen many embryologists have a very quick hand cleaning regime. This is the time we really have to be very aware and alert that the 6-step hand washing is very crucial. So going on to the lab practices, which may need some modification, is again, as per the good practice guidelines issued by ESHRE, they are suggesting that obviously cleaning in between patients, but try and dilute your follicular fluids and semen prior to disposal. So after you've done your egg collection and you need to discard your follicular fluid, dilute it. Maybe you want to do this with water or a disinfectant. Same thing with semen. If you're doing a semen analysis, please try and make sure that when you discard the semen, of course, you're going to do it in a most secure way, where you're going to be shutting the pot quite carefully. And again, same with follicular fluids. Please don't just tip follicular fluid in your bin. Collect that follicular fluid in a pot, which can be tightly capped and be discarded. So all these measures are going to be very important. Try and make sure that you double bag your waste that comes out of your lab, because again, this is clinical waste and that could be harboring infection. Consider daily disposal of sharps bin. Try and go paperless if you can. And I appreciate that many clinics in Africa may not have a very automated data logging system when it comes to computer records or even patient management records. But again, try and minimize hoarding too much paper in the lab in terms of your lab notes and so on. Or if you have to have paper, make sure that only one person in the day is rotated to just take all the notes, so that multiple people are not handling that same piece of paper. Okay, try and avoid using or sharing pens if you can, because again, that could be another contact point whereby we may be passing the virus from one to the other. Sanitation of all the commonly used items in the lab between embryologists has to be thought through. Try and keep dedicated pipette holders, which are individual to the embryologist. Okay, so I know we all share things like pipette holders in the lab, but this is the time to keep everything separate so that we're not using each other's. And of course, even though we're still cleaning and sanitizing all these pipette holders at the end of the day. Okay, and try not to keep open packs of consumables for the next day and so on, because again, the virus survives on anything, even plastic. So you want to make sure that you're opening fresh pair of consumables. I appreciate that there may be another extra layer of cost involved now, but we are moving through very difficult time, guys, and I think we really need to do what is best practice. Now, the embryo transfer, of course, there is nothing to say that a patient cannot have an embryo transfer unless they have become symptomatic, because at that point, you have to cancel the embryo transfer and freeze the embryos. The stand that we have taken in our clinic is partners are not going to be allowed in the embryo transfer. We have to minimize partners coming in for procedures where they're purely there as emotional support. So you would only allow a partner in on the day of egg collection where he's doing a semen sample, or even on the day of embryo transfer, they're not allowed in theater. They have to wait in their car downstairs. So again, very strict measures, but I think this is important. Now, of course, if anyone does experience any symptoms post egg collection, then freeze-all strategy should be also applied. If you have anyone who is positive and has to have an egg collection, then you may want to consider a closed system, closed vitrification system, such as rapid eye, which is quite an effective system to use to ensure that there is no cross-contamination. And of course, there's very limited evidence around any cross-contamination within liquid nitrogen phase. But again, just as a good practice guidelines, if you do have a known positive or symptomatic patient, you may want to freeze their eggs and embryos in a closed system, or consider having another dedicated tank for these patients. We test both the man and the woman during the journey of IVF because they as a couple are very close in their proximity. So it is important that we test both the men and women in the journey. Now, the risk assessment is very important. We have to make sure that the risk assessment is done of staff to staff, patient to staff, sample to staff, and sample to sample. And again, this is not going to be an easy risk assessment because every potential scenario has to be thought through. So I hope I have given you some information about how to restart your lab and some pointers. And of course, this is not the be-all, end-all. There may be many ways of doing things, but this is the approach we have taken here in the UK, and we hope to minimize the risk of any active transmission during the pandemic. Please do feel free to ask any questions if you want to. Thank you so much.
Thank you, sir, for giving a very insightful lecture. And I think you have solved most of the queries in their mind. And we thank you. There are some questions, and I will be asking you. They are asking, what's the real effect of COVID-19 on oocyte sperm, while we know that it has no receptor for COVID-19?
That's a very good question. And the reason, I'm telling you, the things are changing by the day. Initially, we felt that there was no receptors present, but now the latest information that we are seeing is that sperm do have the ACE2 receptor. Ovarian tissue does have ACE2 receptor. The embryo does have ACE2 receptor. The oocyte doesn't have ACE2 receptor. So in theory, this suggests that you can potentially infect the embryo or the sperm. But of course, this is the theory. We don't know that at the practical level whether this does affect it. And I think I've also read of a paper where they have shown a linear transmission from mother to baby as well during pregnancy. So you see, we're learning so many new things. Trust me, 10 days ago, I did not know this information. And, just keeping on top of what's really happening has given us another level of alert, because initially we thought, hang on, everything we do in the lab, yes, we need to be strict, but it's good to know that they don't have the receptors. But now we're learning that they do have the receptors.
Right, sir. As such, it is a learning process. And the second question is, can I use any odorless disinfectant in IVF lab? What about the toxicity? What are the toxic materials that I have to avoid them in disinfecting the IVF lab?
So one of the most common disinfectants used in an IVF lab is called OOSAFE, OOSAFE. I would recommend that you get that because that is widely used. And again, if it's available in your country, try and get that. If you don't have any OOSAFE available, then you may want to have 7X detergent. But again, check whether it's active against COVID-19. But you may want to have 7X detergent. It's called 7X. And you may be able to use it in a diluted way. You have to use it in a diluted way. So these are the two options that I would recommend from a lab because they are odorless. You don't want to start using ethanol and so on.
Right, sir. Sometimes patients may feel the COVID-19 questionnaire given to them with false information. How do we deal with them to limit the risk of staff contracting the virus?
So that's why I think testing is important. Yes, patients may give inaccurate information on the questionnaire, but that's why the triaging, we also check temperatures of patients when they're in clinic in every visit. Of course, I understand that that is a contact point and that's what we're trying to avoid. But it's important that patients go through several layers of triage, not just the questions that they are posing to us or the answers that they're giving us, but also physical symptoms such as temperature checks. So, and of course, testing. As I said, nothing is more vivid than what their status is for COVID-19.
Right, sir. If a woman has COVID-19 and she has to undergo egg retrieval, what is the possibility of oocytes retrieved having the defect resulting to the babies having COVID-19 even before birth?
We don't know enough information at the moment. As I said at the beginning, I would have told you it doesn't have the receptors. Now we are led to believe it does have a receptor. So in theory, you can infect the embryo or the, you can infect the embryo. So as I said, in our, in the UK, if anyone turns out to be positive before egg collection, then you are not allowed to continue. So sorry, if anyone is positive before trigger injection, you have to abandon cycle. If anyone is positive after trigger to the point of egg collection, you have to perform the egg collection but with a view of really making sure that you keep their eggs and embryos well safe from other patients. So because you don't know what the mode of infectivity is at the moment.
Sir, you said that you will be testing the patients on 8th or 9th, 10th day of the stimulation. Then the ovum become. In between, do you test again?
No. So we do a test at the before stimulation, which is an IgG test. And then we would do a PCR test or IgM test on day 8 to 10 of stimulation on both the husband and the wife.
Right, sir. Even the husband comes positive, then also suppose on 8th or 10th day, then?
Yeah, if either of them are positive, their cycle will be cancelled because they are in very close proximity. If a husband is positive today and a wife is negative today, that doesn't mean tomorrow the wife will not be positive. She may be in an incubation period.
Correct, sir. In case of infected patient and we did freezing, when we can do transfer after testing?
This is, again, we don't know enough about it, but I would, once your embryos are frozen, you're not really worried. You don't have to have too much of a rush to transfer them back. I would wait another 3-4 months to see what is happening on a global level or even at the within your country to see what the epidemiology curve is, and then decide, even at a national level, what the guidelines are, because the guidelines are going to be different from country to country based on the epidemiology curve.
When do test when we are performing FET and HSG?
Yeah.
I think it is FET.
Sorry, what's the question? When you're performing FET and HSG, what's the question?
So when do test when we are performing FET and HSG?
Oh, in FET, you would test on the first day of their progesterone. And with HSG, again, what I would do is I would test on the first day of their cycle. But don't forget, with HSG, you may take a view that they don't need testing because you're not banking any embryos.
Sir, you suggested to have to do sanitize the ultrasound probe. How do you practice it? Means what frequency and with what?
Yeah, in between all the patients. So your probe has to be sanitized, which I'm sure was a common protocol anyway. But maybe many clinics were only just using a latex probe cover in between patients. But now this is not just enough. You have to sanitize the probe using an effective sanitation wipe. So we use a wipe called Clinell wipe in between all patients for effective sanitation. Even Tristel is very good. There is a product called Tristel, and again, it is a recommended product for ultrasound probes.
What is the role of UV light in ducts in prevention of spread of COVID-19 lab?
If you do have UV in your ducting of air handling unit, that is amazing, because then even your air coming in would have been disinfected. So if you do have UV in your ducts, that is great. But most air handling units will not have UV. And that's why it's quite important that you put in a fresh pair of filters.
The next question is, when do we test in case of IUI?
If in IUI, again, you may take a view that this is an in vivo procedure, but I would suggest that you test around day 10 as well, because don't forget, ideally, you're going to be doing the insemination anytime from day 12 onwards. You can take a view that you may do testing for all cycles between day 8 to day 10. Again, there is no perfect answer in these things, because it's so arbitrary that we're trying to cover ourselves in terms of the time periods. But it's nothing to say that someone who is negative on day 10 will not develop the virus on day 12.
Right, sir. Thank you for giving us a very practical guideline. And there is another question: which disinfectant will you really recommend for lab cleaning and the probe cleaning? That already.
So for lab cleaning, I suggest USAFE. For probe cleaning, ultrasound probe cleaning, I suggest Clinell or Tristel.
So thank you, sir, for giving us time and giving us very practical points, and for initiating again the ART cycles and ART labs. On behalf of viewers and intas, I thank you.
I really am privileged to be invited. Thank you again to Mr. Pati for inviting me and the intas team. And I'm so sorry I have to leave now. I've just got another commitment that I can't really come out of. But if anyone does have any further questions, please forward them on to me via email through Dr. Satpathy or Mr. Satpathy. So thank you so much. And I'm so sorry I can't stay on, but I will leave the session now. Thank you so much.
Thank you, sir.
Thank you.
So now, after listening to Dr. Alpesh Doshi, we have Dr. V.M. Thomas. He will be speaking on optimizing IVF outcome from embryologist perspective. Dr. V.M. Thomas is a chairman and institute director, Chennai Fertility Center and Research Institute, Chennai. He is embryology scientist and ICSI Master Director of Embryogenesis, the International School of Embryology. He is the President, Fertility Society India, Fellow, Society of Reproductive Biotechnology, 2012, rendered technical expertise to several hospitals all around the globe. He has to his credit many honors and awards. He is recipient of Most Inspiring Embryologist in India, awarded by Honorable Minister Tamil Nadu, Arc of Excellence Award for his outstanding contribution in reproductive medicine and embryology, Rajiv Gandhi Gold Medal Award for his excellent contribution in ART and clinical embryology, Outstanding National Citizen Award for his remarkable contribution in the field of reproductive medicine and embryology, and many more. With this, I welcome Dr. Thomas to begin with his webinar.
Thank you, madam, for the nice introduction. Ronak, can you help me in this?
Sure, sir. What are you facing the difficulty, sir?
No, I want the first slide. Last slide is coming.
Sir, I have raised a request. Can you please approve it?
Okay, okay.
Hello, sir. Are you there?
Ronak, any problem?
Okay. I believe, sir, उनका system restart हो गया है, sir.
Okay.
So we are just waiting for him to reconnect.
Okay.
Can anybody call Doctor Sir to just confirm that, because I don't have his number. I guess he's back.
Yeah. It's fine.
I'm sorry, some technical difficulty.
Yes, sir. Sir, I'll just ask the permission again. So would you
Okay.
please approve it?
Okay, okay.
Sir, can you please share your screen? Sir, where is that presentation? Can you please open that presentation? Sir, is this the current presentation?
Yeah, correct, correct.
Sir, on which slide do you want me to go ahead with?
First slide. Okay.
Sure. Here it is, sir.
Good evening, all of you. This is Dr. Thomas from Chennai Fertility Center, Chennai, India. Is that audible?
Yes, sir.
Today, I'm going to talk about optimizing IVF outcome from embryology perspective. So you all know that IVF is very popular and worldwide, almost all 10 million babies has been born. So IVF is not a very new, and it has been done in 1959. And my slide is going. Ronak, where is my slide?
Sir, I believe that you have stopped sharing your screen, sir. Can you please do that again?
So now, is it okay?
I don't think so. Everybody is able to view these slides, sir. So first you have to do the screen sharing, sir. It is at the bottom, sir.
I have done it.
Sir, I believe that I cannot see your screen, sir.
Yeah, you came out. You came
Cannot
out,
see?
you know.
Sir, I've asked your permission. Can you please give me the permission access?
Given already.
No, sir. I have requested it again, sir.
Is it okay now?
Yes, sir. I'm just putting into full screen mode, sir. Just 1 second. Yes, sir.
Okay, can I go ahead?
Yes, sir.
I'm sorry for all this thing. I'm not a very expert in computer. Because of the lockdown, we don't have any computer person. But anyway, I'll go through. So, is it audible? Ronak, is it audible?
Yes, sir. Yes, sir. It is audible.
Yeah.
You can go ahead, sir.
Okay. So far in IVF, 10 million babies has been born worldwide. On July 25, 1978, the first IVF baby has been born. It has a breakthrough. It's from UK. In 2010, Robert Edward was awarded the Nobel Prize for the medicine for his development of in vitro fertilization. So IVF is a very simple process. You just collect the egg and wash the egg and keep it in the culture media. And then you also prepare the semen, and then you can co-incubate egg and sperm together to make a fertilization. So after 18 hours, you check the QPN, and then further you can check the embryo and then the embryo culture. Then you decide when to transfer, either day 2 or day 3 or day 5, it depends. So these are the two gentlemen is responsible for the first IVF baby, and it came in all the newspaper. And after this IVF pregnancy, so they delivered through a C-section. It's not a normal delivery, and it's a female baby. So the embryologist role will start from the semen analysis. You all know that the WHO criteria we follow. In WHO 99 and 2010, when you compare it, The sperm concentration is 20 million, and after that, 2010 is 15 million. We focus on mainly its morphology. 2099 is around 30%, and then it come down to 14%, and then 2010 it's bring down to around 4%. So when you check the semen sample, the embryo should know that which sample for what. Is it for a natural cycle, or is it for a IUI, or is it for a IVF ICSI, or is it for any other, like a MC procedure. So here itself, the role of embryologist will start. And the IVF is a 5-step procedure, selecting the, like a injection, and then stimulation, and then monitoring of the follicle, and then egg collection, screening of the oocyte, then either IVF or ICSI, then embryo transfer. So embryologist should know that oocyte biology. It should know the mechanism of fertilization, and it should know the physiology of the fertilization. And generally, if the number of eggs, if it's less than 4 or 5, what should we do? Is it IVF? Or if a more egg is there, is it we are going to do a ICSI treatment? Or if the sperm is very bad, what type of treatment you are going to do? So the embryologist should focus on the oocyte biology, and it should know the importance of like a number of eggs and what type of procedure is going to do it. And the handling of the oocyte should be a less exposure, constant temperature maintenance, and assessment of oocyte cumulus complex is very, very important. So as already the Alpesh spoke about the lab, and we should strictly maintain about the temperature. We strictly maintain about the gas, and like a CO2, and then carbon dioxide, and the nitrogen, and the exactly percentage we have to maintain. And we should also maintain the temperature and pH and osmolarity. These are the crucial steps, because if the temperature is very high, the oocyte spindle can damage, and then it can give you the biochemical pregnancy. If you're handling the oocyte for a long time, it can also give you the retarded embryo. So that's why some of the lab, they produce a pregnancy, but finally they have a lot of biochemical pregnancy. 6th week or 7th week, heartbeat will come and disappear, or maybe only an embryonic sac will be there. They don't give a viable pregnancy. The next step is in vitro maturation. This is mainly, came for PCO patient, polycystic ovary patient. There are so many small follicles will be there. And if you do that, sometimes the patient may landed up with ovarian hyperstimulation syndrome. This patient, immature follicle can be collected in the lab. You can mature the follicle, and then it can become an M2. Then you can manipulate the oocyte using the. As I mentioned, control of physical parameters in the lab environment is very, very important. So temperature and pH and osmolarity, gas composition is very, very important to achieve a viable pregnancy. So as the graph mentioned, that if there is a 37 degrees temperature is there, the pregnancy rate is fine. If the temperature drops, the embryo quality and pregnancy rate also go down. And under the oil, when you check, sometimes the temperature fluctuation will be there. You can also see 4-well dish after the denudation, and you can also see the 4-well dish with the warming block. So we think that it's a 37 degrees, but when you exactly measure, it will be little low. So that's why sometimes we have a low fertilization, or maybe the success rate also low. And we mainly focus on either carbon dioxide, like a percentage, either 6% or 5%, or we focus on pH. We have to focus on the pH and maintain the pH around 7.2 to 7.4. So the exposure time is more, like 3 minutes or 5 minutes and 10 minutes. You can see the clear graph here. If the temperature is more, and the pH will increase slowly. So that's why the exposure of the gamete should be less, so that the pH will be maintained perfectly, so that embryo or oocyte cytoskeleton will be safeguarded and give a viable pregnancy. At the same time, osmolarity also very important. You have to maintain the osmolarity. And if there is a sperm quality is very bad, still you want to perform a procedure. You have done previously IVF, none of them are fertilized, or there is a poor fertilization. There is no proper embryo, or maybe because of egg is good, the quality of the egg is very good, but still in spite of your IVF or ICSI, there is a low fertilization rate. So those patients, what we can do is, maybe because of the male factor, female factor is perfectly all right. So you can also do ICSI dish. this dish is coated with the hyaluronan. You can put a 1 drop of the semen sample. The sperm, whichever is good quality sperm, they will adherent to the, like a petri dish, and then you can select those, only those that bind to the hyaluronan microdrops are selected for ICSI. So when you do that, you have a good fertilization, good quality embryo, and also the you can avoid the missed abortion rates. And sometimes you find a challenge. You get a, like a sperms will be there, like a 10 million or 15 million. You have more sperms will be there, but at the end of the day, when you see them, none of them are moving. Maybe you have seen it before; they are good, but on the day of egg collection, maybe after 2 months or stimulation, after on the day of egg collection, when you see the sperm quality, they're totally none of them are moving. So don't require to panic. Sometimes it's called as a necrosospermia. You can use a hypoosmotic swelling test and then apply to the, like a sperm preparation method, and then put it in the hypoosmotic swelling test, and then see which of the sperm is curling. That means, tail is, curled. So those sperm can be taken out. That is maybe mostly it's a viable sperm. Those sperm can be used for ICSI treatment, and you can easily get a pregnancy. Sometimes there is no sperm. Maybe like 6 months ago, you saw them, severe oligospermia. After that, nothing was there. It was, on the day of egg collection, you couldn't able to produce the semen, and you say, "I'm sorry." But given already ejaculation, there is no sperm, but still nothing to worry. You can take to the theater and then put a small needle into the epididymis. You can aspirate the semen, and then you can see. Sometimes you will find this. You will find the sperms. So mostly obstructive azoospermia, and then like a low sperm count and fluctuated semen sample. Most of the time, you can get a good number of sperms or enough number of sperms for the ICSI. So as I mentioned that if the sperm quality is very less, we cannot perform an IVF. For IVF, at least we need a 1 million motile sperms. If there is no 1 million motile sperm, or maybe hardly few sperms are there, it's a severe oligoacinoteratospermia. Those sperm cannot be done either IUI or IVF. This patient definitely they must go for an IVF or ICSI. So they already done an IVF 2-3 times failure, IUI also failure. So we cannot do again IVF. So we must do the ICSI. It will give you the benefit to the severe oligoacinoteratospermia patients. So ICSI is not a very old technique. It's invented in 1992 by Palermo Group, and they also produce a first pregnancy in ICSI. So after that, there are worldwide many clinics started using the ICSI technique, and some of the clinic is 100% they are doing a ICSI. So ICSI is now widely practiced. So if you have any challenge in sperm selection, or maybe previous IVF or ICSI low fertilization, if the morphology is very bad, so sometimes if you see in 20x, you may not able to select the viable sperm. And better if you have a 40x objective, you can little bit magnify the sperm. You can see the clear head shape and the the shape of the sperm. If very big vacuole is there, you can also identify in the 40x objective. You can pick the sperm and then give enough time for selection of the sperm and do ICSI. You always get a good morphological embryo, and when you transfer this type of embryo, you'll also get a good success, and you will have a sufficient embryo for the freezing also. So generally, after the selection of the sperm, you can go back to 20x objective. You can start doing the ICSI in 20x. You have done an ICSI, and then embryos are coming. They are fine. You transfer. The pregnancy is okay. But some of the patients already 4 times, 5 times ICSI has been done. But in spite of like a 2-3 cycles, the female side everything is fine. Only because of the husband's sperm is very bad, or maybe the DNA fragmentation is very high. Those patients are not getting pregnancy even with the ICSI cycle. What you can do is, this patient you can also go for a IMSI treatment. IMSI means nothing. You magnify the sperm around 6,600 times, and then select the sperm without any vacuole. Those sperms can be used for. And you select the sperm, and then you can hold the egg in the holding pipette. Polar body should be either 6 o'clock position or 12 o'clock position. Your needle will be around 3 o'clock position. gently without damaging the oocyte. You have to inject it and then release the sperm back to the. So ICSI is widely practiced, as I mentioned that even if there is a sperm is very less, or maybe oligospermia, or maybe obstructive azoospermia, or maybe you have done a TISA, PISA, or testicular biopsy, or anything. So at the end of the day, we need just sperm cell with a nucleus. Whether either they're not moving or they're moving or they're sluggish, doesn't require to bother. You can male infertility, generally male factor infertility, you will get a good success rate compared to the male factor. And sometimes when you do exceed the old woman or old oocyte or aged oocyte, they may not fertilize, or if they fertilize also, they give a poor quality embryo. So you can also, one type of ICSI you can do that's called as a modified ICSI. What you do is actually, when you're injecting at 3 o'clock position in the oocyte, generally we go up to the 50%. Then you start aspirating the cytoplasm. Then you mix the cytoplasm along with the sperm, and then you push back into the middle, exactly in the in the middle of the cytoplasm to drop the sperm and come out. But you have done previously, but the egg is not fertilized. But this patient, what you can do, you can go a little bit deeper up to the near to the opposite cytoplasm, up to 80% to 90%, and you can aspirate the cytoplasm there. Why I'm telling you there, the mitochondria periphery, there will be mitochondria will be more will be there. Those mitochondria try to pick it up and then mix with the cytoplasm and put it back to the cytoplasm. Mostly you will get the fertilization, and also subsequently you will get the good quality embryo. So if you have a spindle, you can also spindle view microscope. You can also visualize the spindle exactly. And sometimes we assume that the below the polar body spindle should be there, but sometimes in this picture you can see exactly 3 o'clock you want to inject, but exactly there only spindle is present. So when you inject that area, sometimes the spindle may damage, they may not fertilize. So that's why even ICSI you don't get 100% fertilization. Around 70 to 80 or 90% you'll get. And some of the country, like a Middle East and all those places, they are against for the donor egg, so they don't want to use the donor egg, but still they want to use their own genetic material. They want to get a pregnancy. So those patients, what we can do is, the egg will be originally for the same 40-year or 42-year or 43-year-old woman, but only we can take a cytoplasm from the donor and mix with the husband's sperm and aspirate the cytoplasm from the old lady, 42-year-old lady. And then again, you just aspirate the cytoplasm and push it back to the oocyte. They develop a good quality embryo. As I mentioned that, sperms plays morphology plays a crucial role to achieve a good quality embryo. At the same time, surplus embryos also will be there in case you want to do a frozen embryo transfer for second cycle or third cycle, or the patient is already got a pregnant, they want to come for a like a second cycle or third cycle, baby or third baby. You can also choose the sperm. You can magnify the sperm, and then you can magnify the sperm and look for the vacuole, and then select the best sperm. So in this video, you can see clearly there is a sperm moving there, and then it's a magnified around 6,600 times. You can see the big, big chunk of cell. So generally, what we are focusing is here, and we want to focus on the head area, and then see how the sperm head look like. The sperm head, you can closely, if you watch, there are one sperm is very good. This particular moving sperm. There are other sperm. There are other sperm. You have a vacuole. You can see there. So those you can avoid during the sperm selection. Only you can take a best sperm, and then this sperm you can select it and then inject it. You always get the good quality. And also, if there is a sperm factor is there, you can avoid the abortion. Can you mute your video, my dear? Technopark 4R. Please, can you mute?
Yes, sir. I'm doing. Yes, sir. I'm doing it.
Yeah. So can you see the closely? You can watch the sperm. They are nicely moving. In the head area, when you see there is a vacuole is there. Those vacuolated sperm can be avoided. Good sperm can be taken for microinjection. You can get a good success. So selection of spermatozoa with normal nuclei to improve the pregnancy rate with intracytoplasmic sperm injection. So that's why IMSI is the best method for the, if they have a patient has a, male factor, because of the male factor, they're repeatedly getting a abortion. And coming to the culture media, the embryos must choose the culture media. You have a single culture media is there, or sequential culture media is there, or one-step medium is there, or sequential medium is there. Depend upon your lab, depend upon your culture system, depend upon what you are getting in your lab, you can standardize. So generally, some people use a single media, some people use a like a sequential media. You have a lot of variety of media companies there, whichever gives a better like a fertilization, better cleavage, better blockation rate. Those culture media you can stick on. But in our center, we use a sequential media. So day 2 to day 3 we use a like a G1, and then from day 3 to day 5 we use a G2 medium, and then for embryo transfer we use a embryo glue, so that you can get a good number of losses. Transfer 1 or 2, remaining can be frozen for the future use. So as I mentioned, that culture condition is very important in your lab, and if you are maintaining the good ambient lab environment, that means temperature is good, and like a microscope temperature, ICSI temperature, stage warmer, and then oocyte pickup, like a petri dish warmer, or maybe test tube warmer. Everything it has to maintain in an equal manner. That means 37 degrees they have to maintain. One area 37 degrees, other area 35, other area 30, 36, something like that. If the temperature is fluctuating, but you landed up with the trouble. That means sometimes you may produce a more retarded embryo, or maybe the number of blastocysts, the percentage, it has to reach at least 60% of the embryo has to reach the blastocyst, but sometimes you may not get the good quality embryo, or you may not get the like ideal percentage more than 60%. So as I mentioned, that temperature has to be maintained, pH has to be maintained, and the air quality has to be maintained. VOC has to be maintained. It should be very less, and then your pH has to be normal. So if any one of the parameter varies, and you may not able to get a good number of blastocysts, and you may not able to get the viable pregnancy. So here you can see more than 80% of the embryo reaching to the blastocyst. That means you have a very good culture condition. So as I mentioned that, you have a, like a complex media, or maybe, you have a sequential media. Now you can take this embryo to up to the blastocyst. Either you can transfer embryo on day 2 or day 3 or day 5, whichever is, giving a good success rate, you can stick on with it. And generally, if you do a day 2, day 3, the multiple pregnancy will be high. When you go for a blastocyst transfer, you can avoid the multiple pregnancies. And the embryo should also focus on assisted hatching, especially if we are doing a day 2 or day 3 transfer. So if the zona is very thin, like a less than, like a 15 micrometer, they always give a, they nicely hatch, and then they give a viable pregnancy. If the age is more than like a 40 and 41, 42 above, the zona pellucida will be more than 15 micrometers. Those patients require the assisted hatching. You can just thin out using the laser, and then either you can keep it for up to day 5, you can transfer whichever is herniating blastocyst, or you can transfer on day 3 or day 4. They equally give a good. So if you have a good quality embryo, the selection will be easy, as I mentioned that. So the selection of the embryo for the embryologist point of view, it will start from the early cleavage. So exactly less than 24 hours to 27 hours, the embryo has to become a 2 cell. That means the embryo is going for a on-time cleavage. And it has to become a 4 cell, and then it has to become an 8 cell, and then it has to become a compact morula. Then day 5, day 6, it has to become a blastocyst and expanded, and it has to hatch. So if this process, if you see in the laboratory, that means your lab environment is fine, and you're also doing a proper, like a embryology job. And the next technology is called as an embryoscope. So you can observe the embryo directly without exposing the incubator. Generally, like a benchtop incubator, or maybe like a box type incubator. Every time you just take out the embryo and see the the stages of the embryo, and then you change the media, and then day 2, day 3, day 5, frequently you watch. But here, embryoscope with time lapse, you don't require to disturb the embryo from day 0 to day 5, and you can watch the embryo. And these embryo can be, live recorded embryo can be, you can see lively. And from 2 p.m. to up to the blastocyst, you can see. Here, if there is any abnormal fertilization, or if there is any abnormal cleavage, or if there is any multinucleation, or if there is any fragmentation, or they are slow embryo, and still they are forming to the blastocyst, these are all those things can be documented. Whichever is going for on-time cleavage, and then they are behaving like a like a good blastocyst, you can easily select this embryo, and then those embryo when you transfer, you have the implantation rate is very, very high. So embryologist, this procedure also can perform the lab to increase the rate. So day 3 embryo transfer may have a better pregnancy outcome in younger woman, more than 35-year-old woman, even with the poor ovarian response. And day 3 versus day 5, we can also do the embryo transfer. As I mentioned that because multiple pregnancy is high in day 3, multiple pregnancy is less in day 5. Live birth rate is a significant higher in the blastocyst transfer than after cleavage stage embryo transfer, when at least 4 embryos available on day 3 for embryo transfer. So you can go for a kill blastocyst. Patient with 3 or fewer embryos with high, like a good quality embryo, still you can go for a blastocyst. And even one you transfer, still they can get a pregnancy. And also the beauty of blastocyst is reduced ectopic pregnancy rate on day 5, and also embryo transfer compared to the day 3. And so that's why the percentage of ectopic pregnancy also less in day 5 compared to the day 3. So live birth rate, according to the Cochrane review, live birth rate after fresh IVF significantly improve using the blastocyst transfer. Either you can go for a blastocyst transfer or fresh or frozen. They're equally good. So live birth rate following frozen thawed blastocyst transfer is higher if the blastocyst expanded on day 5 than the day 6. That also the live birth rate also published in the Human Reproduction. So day 5, if you transfer the embryo, the live birth rate is, they have reasonably good. And so once you have reached to the blastocyst, still you want to go for a next step. That's called as a biopsy. Either you can go for a polar body biopsy, or you can go for a blastomere biopsy, or you can go for a trophectoderm biopsy. So generally, some of the patient has an embryonic sac, or maybe they have a chromosomal abnormal. Previous pregnancy, she got the abnormal baby, or maybe naturally they have 1 or 2 abnormal baby. Those patients you can perform for a embryo biopsy, and then go for a like a PGD, PGS, or NGS, and then select the embryo, whichever is the euploid embryo. Those embryo can be transferred so that we can avoid the abnormal baby. So these embryo, you can see the herniated blastocyst, and using the like a pipette, you can pull the embryo, and then you can give a laser shot, and then you can take out the trophectoderm cells. Those cells can be sent for the genetic analysis to know whether these embryos are normal or abnormal. So normal embryo we can transfer, abnormal embryo we can explain to the patient, and you can. So that's about the embryo biopsy. And so coming to the PGS and PGD, so mainly the risk of, like a couple for the genetic risk, recurrent mixed abortion or IVF failure, we can consider. Advanced maternal age more than 37 years, we can consider. Couple with previously they have one abnormal baby, you can consider. Or the couple or the both they are carrying the genetic abnormality, you can consider. So pre-implantation genetic screening embryos to the ensure 23 pair of chromosomes. That means 22 autosomes and the sex chromosomes X and Y are present, and there is no aneuploid. So that's why we can screen the embryo and select the euploid embryo and transfer. PGD, diagnosis of the embryo for known genetic disaster that both patients and the partners are carrying, of including sickle cell anemia, or maybe cystic fibrosis, or maybe like a fragile X. So such type of disease can be screened. So why do we need a genetic testing for all? So greater than up to 50% of the cleavage and blastocyst stage embryo producer in vitro are found to be chromosomally abnormal or aneuploid. Aneuploid number reaches higher as 70% in the woman over the 42 years and above. And prevention of inherited disease in the future generation, we can also do the PGD test. You can see here, if the age increases and the aneuploid is going, can you mute please? If the age increases, the aneuploid will go high. So as I mentioned, from 50% up to 70%, the aneuploid rate will increase. So that's why, so you have to screen the embryo before going to transfer. So condition where PGD is advisable, as beta thalassemia, hemophilia, or maybe cystic fibrosis, or Fragile X syndrome. These are the diseases we are focused on. We can do for a PGD. Why perform PGTA? Improve pregnancy rate and implantation rate, decrease miscarriage rate and risk of abnormal offspring, decrease multiple pregnancy and you can do a single embryo transfer, decrease time of pregnancy and emotional burden, and also cost effective. So the PGD is not very new. It has started from 1995. So started with fish, and then 2008, like a RACGH, and then 2012 it's a PCR. Then 2013 is NGS. Now the NGS is advanced, like a validated algorithm they are practicing. Now even with the like a NGS 3 point PGTA 3 they are practicing. So whatever it may be, this technique, from fish to up to the like NGS is more promising, and the accuracy is 100%. After screening the PGS using the NGS, we can see we are going to find out which one is a normal, which one is a abnormal, which one is a mosaic, and which one is a normal mosaic. We are going to find out. The green color, the green, light green shows the normal one. The red color is the abnormal embryo, and you can also see the mosaicism in the third embryo, and fourth embryo mosaic and mosaic. So that's why when you do the PGS, you can know which is the like a viable embryo. Those embryo can be selected and transferred. They can achieve a good success. Gamete freezing, you can also freeze the oocyte, you can also freeze the sperms, you can also freeze the embryo, you can also freeze the testicular biopsy tissue, and you can also freeze the ovarian tissue. And when you're freezing, slow freezing and vitrification, so now we are all moved to the vitrification. Why? Because the vitrification is given a high, survival rate, more than a 90%, 97% compared to the slow freeze. And it's very simple procedure. You can vitrify as a pronucleus. You can vitrify day 2 embryo. You can vitrify day 3 embryo. You can vitrify even blastocyst also. You can vitrify. In slow freezing, it takes a long time. Around like 2 hours it will take. But whereas in vitrification, just hardly like 10 minutes is more than enough to finish the procedure. So when you're especially loading into the vitrification, like a vitrified embryo, so avoid, loading the more embryo. It should be less than 2 microliters. So like what the picture shows. So when you load the less, like a volume, media volume along with the embryo, the survival rate is very good, and also the blastocyst expansion also very good, and the pregnancy also you see very good. So generally, you have to use a less than 2 microliters. And as I mentioned that, if you want to achieve a good success rate, quality management system is you have to maintain, and you have to do a quality control and quality assurance. And so when you do that, you have the embryo quality, or like a blastocyst percentage will be very good. Your success also very good, and take-home pregnancy also, they will give you the good success. So coming to the conclude to my topic. So embryologists play from starting from semen analysis to up to the PGS and NGS. You should know how to select the, like which patient for what during the semen analysis. If the semen sample is good, you can go for IUI or maybe natural cycle. If the semen sample is like a poor, or maybe 1 million to less than 1 to 5 million, go for IVF. Less than 1 million, it's a poor sample, go for HC treatment. Previously, they failed, like a repeated fail due to the male factor, or maybe the sperm has a more fragmentation, or maybe the sperm has a DNA fragmentation levels are very high, or maybe like a previously 2-3 times 6 years failed. So embryologist has to they have to focus on the sperm morphology and go for AMC, so that due to the sperm factor, if they're getting a repeated, abortions, you can avoid using the IMSI technique. And you can also go for a blastocyst. Suppose previously day 2, day 3 transfer is not working, many times is negative. You can also see how the embryo progress up to day 5. Some of the embryo sometimes you can arrest day 3 or day 4, so that you can explain to the patient with the what you have seen and the options. So when you're going for blastocyst, the embryologist should know how they are quality and what is the grading, and you can transfer. And you should also know about the good vitrification technique. And also when you're freezing and thawing, the survival rate has to be more than 95% and above. And you should also know how to do the embryo, like a blastomere biopsy or maybe topograph biopsy, and for the NGS. So low success of artificial reproductive treatment is observed in the embryos that are detected from the numerical chromosome abnormalities. Aneuploidy clearly has a determinant effect of efficacy in ART. As we mentioned already, up to 70% of the chromosome abnormalities are often observed in the case with results in spontaneous abortion. So that means selection of normal euploid embryo transfer during IVF, it will improve the rate. So coming to the conclude, the embryologist plays a crucial role. I mean, from the oocytes to up to the viable embryo. So we have to check the stimulation protocol and the quality of egg, and we have to do a proper ICSI and the selection of the media and the handling of the gametes and the maturity of the gametes and the percentage of oxygen level in the incubators and the other wherever is applicable, and maintaining of the temperature and maintaining of the pH, and doing a proper biopsy, and then sending for a PGS, checking for aneuploidy. Then finally, when you transfer, you will get a viable pregnancy. So embryologist plays a crucial role in all these steps to achieve a good success rate. Thank you so much.
Thank you, sir, for giving us very insightful lecture and with very nice images and videos, and giving us a practical hints for each point. There are some questions I'll be asking you. Then one question, need to know the tricks for ICSI success in labs for embryologists.
Okay, so generally people think that they have to do a very fast ICSI, or maybe I have finished the ICSI in like a 1 second or 2 seconds, something like that, and that is not correct actually. So when you're doing the ICSI, you should be very calm and very focusing on the sperm, and generally go for a 40x objective, and then look for the sperm, take enough time and look for a good quality sperm, and then you can inject it, and then you see the fertilization level also more than 90% fertilization will be there, and the embryo quality also very good. And when it's you culture to the up to the day 5, you will get a more than a 60 to 80% blastocyst. You can transfer few remaining, you can do the freezing. People says that the sperm quality doesn't matter, whatever you push you'll get the success. That's not true. So generally like a 1 second or 30 second or 1 minute per oocyte, that will not applicable here. You have to focus on the sperm, select the best sperm, and then inject it. You will always get a viable embryo. When you transfer this embryo, the implantation rate will be very, very high.
Sir, which is the best media?
So I'm not, promoting any media here, like a company person, but generally I practice here. I use Origio, I use many media like Vitrolife and all those things. For me, like a sequential media, any media is better. Either Vitrolife or any other media, sequential media is better. In my center, I'm using a Vitrolife. They give a good embryo and the good, like a fertilization rate, and we also get a good blastocyst, and also we get a good implantation rate.
Sir, can you just brief us again on quality control of IVF lab temperature, CO2 levels and all this?
Generally, what you see in the IVF laboratory is not very true. Display, you should not be, go for a display. So generally, when you check the display is around 37 degrees, but the original temperature inside when you put the probe, it may be 34 degrees or 33 degrees or 35 degrees. There we do a lot of mistake, and So you have to follow the strict, stringent criteria. Every day morning they have to come. Designated embryologist has to come, check for the temperature in a petri dish warmer, or like a surface of the laminar airflow, ICSI, like a thermoplate, and maybe egg collection area, that is petri dish warmer, or maybe the test tube warmer. Everything daily they have to check with the temperature probe, and they have to calibrate. So it should not vary from one place to other place. When it varies from one place to other place, it will damage the spindle and it can give you the retarded embryo. Even if you transfer, they will get a pregnancy, but finally you may get an embryonic pregnancy, or maybe 8 weeks or 9 weeks, you may lose a pregnancy. So that's why, as I mentioned, that every environment, wherever you manipulate the gametes, all the environment equally has to maintain the 37 degrees. So most of the people, they miss this one. And also you have to maintain the pH in the, like a benchtop incubator, or maybe, like a box incubator. Everywhere you have to maintain the temperature and pH, and as well as the osmolar. In these three parameters, like a basic parameter, if you maintain, your success rate will be very good, and you enjoy it.
Correct, sir. What measures are you planning to take after restarting after this COVID-19?
As Alpesh is mentioned, we are also in a, so much of stress in our clinic, because we have per day 250 OPD will be there. Now we bring down to only like a 30 patients per day. He is mentioned in the morning and the afternoon and the evening. We are practicing the same, because we have a large number of patients, and we are also seating arrangement also. We have done the properly, so that they maintain the distance. Every patient, they must wear the like a mask, and they have to maintain the distance. And in the lab, we are also doing in a rotation basis. We have nearly 10 embryologists we have, and so today if 2 people comes, tomorrow other 2 people will come, then next day other 2 people will come. So like that, rota, we are doing that, and we are maintaining. And the doctors are wearing PPE kit for egg collection. And every procedure, we are also washing the probe, and we are maintaining, we are changing the probe cover, and strictly we are following the X-ray guidelines.
Thank you, sir, for giving us. There are so many questions pouring in, but due to the time constraint, we will conclude here. And they all have complimented you and Dr. Alpesh both. I thank you on behalf of INTAS and all the viewers.
Thank you, Mr. Satpathy has given a good platform for me. First time I'm doing a webinar. I'm not a very famous in the laptop. We always work in the lab. You all know that we are not much about the gadgets. So because today is a holiday, and off day OPD, so nobody is there to help me in the system. Anyway, I thank so much for the Ronak and who helped me in the presentation. Once again, I thank INTAS. I thank Satpathy ji.
Thank you so much, sir, and thank you so much for such a beautiful talk. And I think all the audience must have got a very good take-home message. And I would like to thank all the audience for joining us in this webinar. And we look forward to conduct many more such webinars for all of you. Thank you so much.
Thank you so much. God bless you all.
Sir, you have to stop your screen share, sir.
How to stop?
Sir, you can see that at the bottom of the Zoom screen, there would be a green button indicating a share screen with an arrow sign. There would at the bottom, sir.
Yeah. That's true.
So, yeah, just click on the stop share screen button, sir. Yeah, that's it, sir. Thank you so much.
Thank you so much. Thank you.